Just look at 3 cases. I told you that sometimes in other countries, I wouldn't be surprised if I would say in this country as well, people were doing restorative dentistry. They were working right along, and all of a sudden they saw red, or there was a pulp exposure, or there was an old previous pulp cap, and they chipped that out. They're in the pulp. They would just squirt paste in and go right on with treatment. And when I say go right on with treatment, I didn't say excellent treatment. This is like completely, this was dentistry done for laughs. It's dentistry that's bound to be repeated. If you look, I mentioned the flare-ups, didn't I? Did I not mention the flare-ups? You have more potential for flare-ups. I said you have more potential for resorptions. And I said, and I didn't say, you have calcification. Calcification. When you squirt paste against vital tissue, that tissue starts to narrow. That tissue starts to pull down, and you begin to see remnants of canals, wild apical third. It disappears. We expect something there, but you'd probably see it better if I got all the writing out there. Distal root looks like it stops about there, so that tends to suggest that we have different curvatures. Take different views. Treatment plan for no surprises. The crown is out of there. You know, these are 2-hour cases. You know, I'm not embarrassed to say back in the day, sometimes they were 3-hour cases. I hear young kids today, gee, I had to reappoint. Yeah, because it wasn't done yet, right? So be your word and do it right. And if you have to reappoint, you know, there was a wonderful log by Cami Ferris on the AE discussion forum, and it's all about what we're just talking about. Going back to get an MB2, she could not get through. On a second visit, she reappointed. The staff was dejected that she didn't just go to surgery, and she got through it. She said she did a dance, and then she told everybody on the forum, well, it wasn't a real dance. It was a dance in my head. All right, but that's how excited you get. So we can isolate the tooth. We have a pulp chamber for our reagents. We can get nice shapes, nice smooth flowing shapes, but does it work? So you look at these lesions pre-treatment, you look at how large these lesions can be, and you watch the inevitability, the capacity of the bone to heal is terrific. Notice in this view, we have 2 portals of exit. Right here, you would say, oh, Cliff, merging systems, 1 apical portal of exit. Take the other view, please. All right, so things work. I left a post space for this dentist, and of course, he thought placing a pin would be probably really exciting because we can all worry about a fracture now. But right now, the bone is looking very, very tight. You see that? But the bone looks very, very tight in that furcal area. Another paste case. Okay, so I showed you one was a pulpotomy. It was pretty much confined to here. This guy got paste pretty much, you know, apex is down in here. This is apex there. Geez, this is like AI. You know, we talked about AI earlier in this segment. I'm using color boxes. I'm doing segmentation on the film. Before Ruddle had segmentation, my goodness, and I got a root over here. It goes like that. So what is this tooth? This is a radix intramolaris. You know, you have a radix paramolaris. That's the extra root on the buccal, but the extra root on the lingual is the radix intramolaris. So it has an extra root, and it has all the thrill of a paste. And it's got big lesions, and it's got proximity to the neurovascular bundle. What will we do? We will go in there and spend 2 visits at about 2 hours each, and we'll chip that stuff out. I can use some of the things I've told you about because this is pretty much a straight shot. That's a straight shot. I'm pretty good to there, but now I have a different orientation. I have an angle in here, and that is an angle I have to think about. So I have to be careful what I'm trying to put around the curve. Now, this extra root got filled. You can see at this recall, this is about 6 months, maybe it was a year, but if you notice the size, you can see now we're really getting small. Maybe a little bit, we can do a little bit right in here, but nice PDL in there. Everything's working fine. Remember, endodontics is a regenerative procedure. If you extract the tooth, bone works. Extract the root canal system, leave the tooth behind, bone works. And we'll look at the last case. Well, I got to use red on this one. This is really going to be fun. I don't know if we'll see red, but I really wanted to point out the power of leaving a root behind. Oh, yeah. There's the root. Let's take it away. See it? That's AI segmentation. It's starting to show you little boxes and arrows and callouts where you should be looking a little bit deeper. All right, so we got a silver point in one of the mesials. There should be two, right? Don't we normally think there's an MB? And don't we normally think there's an ML? Okay, so we got probably a missed canal, got a silver point. But this was once, we had one, basically what? In the pulpotomy, first case. Then we went down to about the junction of the middle apical, 1/3, second case. Third case, you can see paste almost. I think the paste is right there. So that means it's pretty dense and it could be easier to get through. Like a lot of the paste cases in North America had cut roll. So they had that anti-inflammatory, and it kept the whole material, it kept it kind of soft. So yeah, we had the same resorptions, potential for mineralizations, calcifications, and we said post-op flare-ups, but we could get it out, unlike the ones we saw that were typically offshore. So that's the case. The dentistry isn't good either. So a lot of these retreatment cases, it's just a whole mindset of the person who refers the case, assuming they did the work. So you can see this lesion. I think you can see it quite well. It's very big. I think you saw this lesion. So post-treatment, you wouldn't think it would get any better, but I mentioned resorptions. I've never seen a lateral canal that big. That was probably a lateral canal that had tissue in it that wasn't removed, and that inflamed tissue began to eat away at the canal. The tissue might have even gotten more inflamed when the paste touched it because it was like caustic. It was cytotoxic, all right? So I see that. You see that rope. We're using a really good sealer. Watch that sealer hold up. Watch that new bridge. Got a new bridge on there. And essentially, again, the thing that always made it exciting for me, the inevitability of the bone to come in and grow after eliminating the root canal space as a source of contamination to the periradicular tissue. So that's my little job on paste. That doesn't tell you everything, but we've talked about all the other filling materials. So the producer said, Ruddle, you need to get in there and talk about paste. It might not be as popular as it used to be, but there's still cases out there and they need conservative non-surgical retreatment. So what's my last call? My last call to action is look at the graph. This isn't gutta percha. These are sealers. So we've always used pretty much Grossman type sealers, and you can see they've been, okay, I don't know what the numbers are. Nobody knows what the numbers are. The literature doesn't know what the numbers are. The numbers could be how many paste cases were treated worldwide last year. Okay, we don't know. So this just means increasing number of cases. You can make it, it's a concept graph. It could be in your community. It could be in another country. It might look like a little different. But anyway, we had the Grossman type sealers and they were very popular and they've been used. You taught them in dental school, okay? They started to fall off. They started to fall off a little bit along the journey because we started to see things other than zinc oxide eugenol. We started to see resin, methacrylate. We started to see tricalcium silicate sealers. So we started to see a different family. Then there was minimally invasive endodontics. The skinny shapes led to single cone. And of course, everybody got really excited about the tricalcium silicates because they were regenerating materials. We're going to explore that at another time, but it's taking off. So whatever this slope is losing, it seems to be replaced by that. And then, of course, your paste cases have just been getting lower and lower. So I'll leave you with this. What is the burning question? What about the tricalcium silicate sealers? We'll be dealing with that. Stay tuned.